Do you ever wonder why you suddenly feel very thirsty, lose weight without trying, or develop gallstones? These seemingly unrelated problems can sometimes be clues that a rare tumor called a somatostatinoma is at work. In simple words, a somatostatinoma is a small growth in the pancreas, or sometimes the duodenum, that makes too much of a hormone called somatostatin. This hormone tells many other hormones to slow down, so when there is too much of it, you may notice the symptoms above. Let us walk through what causes it, how it shows up, and what doctors can do about it. Most people with somatostatinoma don't know why they got it. The exact cause is often unknown, called sporadic. However, a handful of genetic conditions raise the risk, such as multiple endocrine neoplasia type 1, MEN1, neurofibromatosis type 1, NF1, and von Hippel-Lindau disease, VHL. Think of these as family history, red flags. If you have a close relative with any of these syndromes, it's a good idea to tell your doctor, because they might keep an eye on your pancreas with routine scans. Imagine you have just finished a big meal and feel a sudden uncomfortable fullness, then later notice oily stools that float, steatorrhea. Or picture waking up with a new diagnosis of diabetes, even though you have never been overweight. These are classic signs of a somatostatinoma. New onset diabetes or worsening blood sugar control. Gallstones or pain in the upper belly. Oily, foul-smelling stools, fat malabsorption. Unexplained weight loss or feeling weak. Occasionally, abdominal pain or a small mass you can feel. If you notice 2 or more of these together, it is worth bringing them up with a health professional. How do doctors find out if a somatostatinoma is the culprit? First, they will order blood tests to check hormone levels high somatostatin and basic labs for diabetes and liver function. Imaging studies such as a CT scan or MRI of the abdomen can show a small tumor. A special scan called a somatostatin receptor scintigraphy, or G68DOT, a TEPET-CT, lights up cells that have many somatostatin receptors, making the tumor easier to spot. If a lesion is seen, a biopsy tiny tissue sample confirms the diagnosis. Treatment usually starts with surgical removal of the tumor if it is small and localized. When surgery is not possible, doctors use medicine that mimics somatostatin like octreotide to block excess hormone effects. And newer options, such as peptide receptor radionuclide therapy, PRRT, that delivers targeted radiation to the tumor cells. Managing diabetes and gallstones separately is also part of the care plan. Because somatostatinomas are rare and their exact cause is unclear, there is no guaranteed way to prevent them. However, staying on top of known risk factors helps. If you have a genetic syndrome, MEN1, NF1, VHL, follow your doctor's advice for regular screening. Living a healthy lifestyle, balanced diet, maintaining a stable weight, and avoiding smoking keeps the pancreas in good shape and may lower the overall risk of pancreatic tumors. If you notice any of the warning signs listed above, early medical evaluation is the best prevention against a delayed diagnosis. Research on somatostatinoma is moving forward fast, even though the disease is uncommon. In the past few years, doctors have refined PRRT using a radioactive molecule called Lu-177-DOTATATA, which has shown promising results in shrinking tumors and improving symptoms. Scientists are also studying the genetic makeup of these tumors to find targeted drugs that can block growth pathways. Another exciting advance is the use of high-resolution Ga68 DOTATAT PET CT scans, which can spot very tiny lesions that older scans missed. These tools are giving patients more treatment options and hope for better outcomes.